Welcome back from your lunch break. We will now move on to our next speaker. My name is Christine Thompson, and I am the District Stroke Coordinator at the North Bay Regional Health Center. It is my pleasure to introduce Carrie Linklater to you today. Carrie completed her Bachelor of Science in Psychology with a major component of her studies in neuropsychology. She presented research at the Society for Neuroscience in Washington, D.C. in 2005 before moving to Brisbane, Australia, where she completed her master's in the study of clinical speech and language pathology. Carrie has worked as a speech pathologist at the North Bay Regional Health Center since 2009. She has provided services to acute and rehab patients in both an inpatient and outpatient setting. Currently, Carrie is the lead SLP for her department and works primarily in the outpatient Neuro Day program and has a special interest in dysphagia and the completion of instrumental examination. She continues to be passionate about her work and the patients in her community. Welcome, Carrie.
Thanks, Christine. And thank you to everyone who is attending today. How lucky are we to have a virtual platform that allows us to continue our education and professional development? It has been a hard couple years, so it is nice to come together in some capacity and continue to have these learning opportunities. I'm honored to have been asked to speak to you today about a topic that if you have ever worked with a speech pathologist, you know is an important piece of our treatment for acute care, especially for patients with dysphagia, oral care. Now, I know the act of oral care may seem like a modest task. However, as I hope you learn today, it is an integral and vital component to supporting patients with dysphagia, not only in the treatment of aspiration pneumonia, but it is also important in preventing aspiration pneumonia from occurring in the first place. Now, there is a lot of research on this topic. Essentially, I am presenting on 3 topics that all warrant their own discussion: dysphagia, oral care, and aspiration pneumonia. So limiting the information to what I feel is most important has been challenging. I hope I have narrowed this talk down to the important points for you, as the goal of my discussion is to present information in support of the importance of oral care in the fight against aspiration pneumonia in patients with dysphagia following a stroke. My learning objectives are to provide you with some practical skills to take back to your next shift and implement, as well as hopefully open the discussion with your SLPs and stroke units in ensuring you have an oral care procedure in place for this vulnerable population that we work so closely with. I want you to appreciate the benefits of oral care and the vital role it has in our stroke population. So let's get started. Oral care. We all need it, we all do it. Studies have reported that adequate and consistent oral care can increase your lifespan. However, when a patient is admitted into a hospital, it is this basic activity of daily living that is often missed or overlooked. This is especially true for patients who are dependent for oral care, like many of the patients we see during the onset and acute phase of a stroke. Oral care is a basic need. In your nursing best practice guidelines, in a document entitled Oral Health, Nursing Assessment and Intervention, oral care is an expectation by both clients and their families that when entering a healthcare provider's office, or in our case, a hospital, that the individual's healthcare needs will be met. Oral care is a part of that basic set of needs for maintaining good health, as well as overcoming current illness and ailments. Today, we are going to focus on the relationship between oral health and how good oral care can reduce the risk of aspiration pneumonia in patients with dysphagia following a stroke. Let's begin by reviewing some of the basic information of dysphagia. What is it? Dysphagia occurs when muscles involved in chewing, swallowing, or breathing are affected. This may impact our ability to manipulate and control food in our mouth, respond to the presence of food or fluid, secondary to a sensory impairment, as well as impaired timing and coordination to initiate a swallow that may result in an unprotected airway. Dysphagia may also be secondary to a patient's level of alertness and attention during intake. It may also present as a loss of independence during intake, resulting in a patient who requires total feeding assistance. It is not one size fits all. The characteristics of dysphagia are individual, and so is the assessment and treatment plan. When we consider a patient's journey following a stroke, dysphagia can be observed in up to 70% of these patients. Although there may be some improvement in severity following the initial 7 days post-stroke, many patients experience symptoms of dysphagia long-term. The severity of dysphagia is individual and dependent on the location and severity of the stroke itself. Dysphagia has been associated with increased mortality, dehydration, and malnutrition. In some cases, it may also lead to social isolation. Many of us have worked with patients who choose not to attend dining areas as a result of their dysphagia and the new challenges that they are navigating during mealtime. Obviously, the prevalence of aspiration is also increased with patients who have dysphagia, and this is an area that we will explore further. It is important for each patient entering your facility with a stroke diagnosis or symptoms to have a review of their swallow. As a part of our Canadian Stroke Best Practice Guidelines, patients admitted with a stroke should be screened with a standardized dysphagia screening tool to observe for any initial symptoms of dysphagia. This is to ensure a patient is safe to commence the oral intake of both their nutrition, food and fluids, as well as medication. You may be familiar with the STAND or the TORBEST or another tool as outlined in section 7.1 of our best practice guidelines. A dysphagia screen completed by yourself and nursing staff at the hospital is one of the first tasks that may be implemented at the time of the admission. Following this screen, if the patient is considered safe for oral intake, will allow the administration of oral medications to commence, as well as ensuring the patient is able to have access to food and fluids to allow for nutrition and hydration to begin. In some cases, the patient may be designated NPO or nothing by mouth following this dysphagia screen and until a comprehensive evaluation of the patient's swallow is able to be completed by a speech-language pathologist. This comprehensive evaluation completed by the speech pathologist will further guide the treatment plan and may support the initiation of a modified diet or alternate form of nutrition, as well as direct the need for alternative form of medication administration. The risk for possible aspiration pneumonia is at the forefront of both the dysphagia screen and the speech pathologist's assessment. We want to limit this risk while ensuring the best possible outcome for the patient. Safety, quality of life, and overall risk must be considered. During the clinical evaluation of the patient's swallow, the speech pathologist must consider a patient's risk for aspiration pneumonia. During the patient's chart review, completion of the oral motor exam, and throughout the swallowing assessment, the following predictors of aspiration pneumonia must be considered. Is the patient dependent for feeding? And do they require assistance at any time during a meal? Are they dependent for oral care? Will they require support from staff or family to ensure their oral care needs are being met? Do they have any tooth decay? And what is the general status of their oral hygiene? Does the patient require alternate forms of nutrition? And how are they currently receiving their nutrition? What does their past medical history tell us? Do they have multiple medical concerns that must also be considered during their assessment, and what impact do these have on the patient's swallow? What medications are being prescribed for this patient? And will these impact the patient's swallow? And is there a history of smoking? Interestingly, dysphagia is not identified on this list. Dysphagia, although an important risk for aspiration, is generally not sufficient on its own to cause pneumonia unless other factors, as we just reviewed, are also present. So along with the patient's severity of dysphagia, there are so many other factors that we must consider. So what does this mean? How does dysphagia and aspiration not conclusively result in pneumonia? Aspiration can be identified in approximately 30% of the stroke population suffering from dysphagia and is in the most important acute complication associated with dysphagia. Clinical research has exposed the complex nature of aspiration pneumonia and considers a group of 3 significant factors, the 3 pillars of aspiration pneumonia. So if you look at this slide, we have 3 pillars all representing different things. The first pillar on the far right represents impaired health status. On the far left, impaired health status. Every patient admitted with a stroke has an impaired health status, and it is easy to recognize that the severity of the stroke directly impacts the impairment of this factor. The second pillar on the far right is impaired oral pharyngeal environment, or bacteria colonization, especially the bacteria colonization. As you can guess, this is the exact indicator that points us in the direction of oral care. And the final pillar represents impaired airway protection. As a result of a stroke, there are changes in the brain, both motor and sensory that can be impaired and may impact the mechanics of a swallow, a patient's ability to recognize the presence of a bolus and slow the response of initiating a safe and timely swallow. These characteristics of impairment are evaluated during that clinical swallow assessment and define the severity of the patient's dysphagia. So the idea behind these 3 pillars is that aspiration pneumonia can only develop within the context of a primary or serious illness. And it's been published that aspiration pneumonia will not and does not develop as a singular and independent disease entity. When these 3 factors, impaired health status, impaired oral pharyngeal environment, and impaired airway protection occur on their own, our risk for aspiration pneumonia is less. When they co-occur, we have a situation where the risk for aspiration pneumonia is at its highest. So let's look at this table for a minute. When we are considering how a patient may respond to oral intake and what that may look like from a safety perspective, we want to consider those 3 pillars when predicting the risk for developing pneumonia. If we look at this table and we focus on row 7 and row 8, we see that the only difference is the oral health. We see that the prediction can go from high risk to low risk just by adopting good oral health status of the patient. Their risk for aspiration and their immune system are both compromised in both cases. It is also interesting to consider rows 3 and 4, where aspiration is present for both. However, the predicted outcome of pneumonia is no pneumonia. So this further emphasizes that laryngeal aspiration related to dysphagia is not the sole cause of aspiration pneumonia. Now, if we consider these factors immediately following a stroke, we have little control over airway protection and health status. Often we must wait for medication to be prescribed and take effect, for some spontaneous recovery to occur, or some other medical intervention. But from the time of admission, we have the most control over the oral pharyngeal environment. How? Oral care. So if oral care can reduce the risk for various diseases and aspiration pneumonia, why is this treatment often overlooked? Let's see if we can change that. I want to start by reviewing some interesting facts about oral bacteria to get you thinking about what is actually happening in both a healthy and unhealthy mouth. We have all seen a mouth that looks like this. Hopefully not on a daily basis, but I guarantee you have all seen this mouth. Let's consider some of these facts. First off, did you know you can collect 10 billion microorganisms by scraping a small section of your tooth in the morning before oral care? 10 billion. Think about that number. This is why one of the first things we do in the morning to feel human is brush our teeth. Number two, in our mouth, there are more than 600 species of bacteria. That's what we want to get rid of. Number three, poor oral care results in the development of a dense bacteria biofilm. For patients with dysphagia, if this is aspirated, may increase their risk for developing aspiration pneumonia. And finally, plaque can recolonize on a tooth surface just 3 hours after cleaning in a healthy mouth. For individuals with periodontal disease, it can begin to recolonize just 5 minutes after cleaning. So for many of our patients with suboptimal oral hygiene, that plaque is coming back as we're walking out the door. All of these facts make me want to go brush my teeth. But what can we do about it now? This is what we're here to talk about: the assessment of oral care and the implementation of treatment as a source of prevention from the time the patient is admitted with their diagnosis of a stroke. So we know that aspiration pneumonia does not happen because of dysphagia alone, and that there are co-conspirators, all those 10 billion microorganisms, as well as the other predictors of aspiration pneumonia, as were discussed in earlier slides. Poor oral hygiene has been related to several medical conditions, including cardiovascular disease such as a stroke. Good oral health can support the prevention of many diseases before they manifest in a person. And this is why oral care is a component of our stroke best practice guidelines. This guideline states that an appropriate oral care protocol should be used for every patient with a stroke. This guideline goes on to identify examples of this oral care in the evidence list for this indicator, and they are highlighted here. These guidelines indicate that people with a stroke should have mouth care at least 3 times a day, including brushing of teeth and cleaning of gums with a suitable cleaning agent, removal of excess secretions, and application of lip balm. For those who have dentures, the dentures should be put in during the day, cleaned regularly, and checked to ensure a good fit. It identifies that staff should be trained to provide oral care to all stroke patients during their admission following a stroke, which would include assessment of oral care, selection and use of appropriate oral hygiene equipment, provision of oral care routines, and awareness and recognition of any swallowing difficulties. It is also important to ensure the patient and their families receive information and training in mouth care. If the patient is capable of participating in their own care, it is important for them to understand the role oral care has in their healing process, and to ensure they take on that role with the same understanding that we have. As nurses, you have the training to complete the oral care assessment and treatment. It is a component of your nursing standards, as well as the stroke best practice guidelines. You are the champions on the floor. And as a speech pathologist, my colleagues and I look to you to enforce this important piece of the patient's treatment plan. Our mouth is the gateway to health. Transportation of that bacteria with the food we eat, if aspirated, can be what leads to that aspiration pneumonia, and this is preventable. So how does the assessment and intervention of oral health look to you? Let's review the tools and the know-how. I want you to feel confident in making the decision for oral care. Know who to discuss the treatment plan with, and value the importance it has for your patients, for their safety and support in their healing process. The image I have on this slide is actually from your best practice guidelines, the nursing assessment and intervention for oral health. So as a part of this best practice guideline for oral health, this information for what a standard assessment of the oral cavity might look like is all there. You are the first to lay your eyes on the patient. In order to determine if the patient is able to initiate oral meds, a review of the patient's swallow must be completed, that standardized dysphagia screen. As part of this, you should be evaluating the oral cavity and providing oral care prior to initiating that screen. Because at this point, you are unaware of the patient's swallow ability or when the last time they completed any oral hygiene measures. By not assessing the oral cavity or completing oral care, we may be putting that patient at risk for aspirating those 10 billion microorganisms if oral care is not completed at the onset of your screen. During the assessment of the patient's oral health status, it is important for all of the structures of the oral cavity to be observed and evaluated. In the nursing practice guidelines, there are several tools available that may be utilized to support your assessment. Use of these tools promotes a proactive attitude to the patient's care. I will touch on some of the oral evaluations as they are set out in your nursing best practice guidelines. The first one is the OHAT, or the Oral Health Assessment Tool. It is for use with non-dental professionals. This tool provides a systematic way to assess the oral cavity. It categorizes findings into 3 categories: healthy, changes, and unhealthy. It is a validated tool for assessing various aspects of oral health status and is used to differentiate between healthy and unhealthy conditions associated with the oral cavity. A score of 0 on an indicator represents healthy. A score of 1 represents changes observed and may warrant an intervention such as a medication review or patient and family education. And a score of 2 representing an unhealthy status, which may warrant a referral to an oral health professional. This evaluation allows you to track changes across time, which may also reinforce the need for more frequent oral care. The next tool is the THROAT, or the Holistic and Reliable Oral Assessment Tool. And like the OHAT, it reviews the lips, the tongue, the gums, saliva, and both natural dentition and dentures. The same structure is used to evaluate each area of the oral cavity and determine if further intervention is required. The point of my showing these tools to you is so that you know there are resources out there to guide you in the identification of areas of concern in the oral cavity that let you monitor for changes. A patient's mouth can tell you a lot about how they are doing, so take a look. Now that your assessment and observation of the oral cavity is complete, it is time to move on to oral care. Although at some point an SLP may become involved and initiate an individual treatment plan for the patient's oral care, it is important that you begin the oral care and a basic type of oral care as soon as you can. So let's review what basic oral care looks like for the patient. We're going to review some tools you might see at your facilities and discuss how and when to use them. So when does oral care begin? When does it need to take place? Patients admitted with a stroke should receive oral care as soon as possible. As we discussed before, one of the first tasks completed on a patient is that dysphagia screen in order to determine an administration route for medication. And prior to that screen, oral care must be completed in order to reduce the risk of aspiration of any unwanted bacteria. When we are left with the task to complete oral care, We must make the decisions of knowing what to use to complete that oral care. Selecting the use of appropriate oral hygiene equipment and cleaning agents can be just as important as what you do with them. So what do I use and when? Some of the tools we are going to review you may be familiar with. Some you may be too familiar with. And some we want you to start to consider as the standard for oral care. So let's start with some of these tools. The first is the toothette. Although it's a popular, very popular tool for oral care, it is often the first and only tool used. But on its own, it is not sufficient enough to properly clean the mouth. The toothette has a purpose, but it is not to provide comprehensive oral care. The purpose of the toothette is to clean out large amounts of secretion, remove debris, such as residue following a meal, or moisten structures after we have completed a comprehensive oral care. The toothette is like tidying your house before the cleaning begins. And so brings us to our proper cleaning tools, our toothbrush and toothpaste. Once we have removed the visible debris and excess secretions with the toothette, we want to begin the more sophisticated cleaning with a toothbrush and toothpaste. Use of these standard tools is essential in our own daily routines and must also be considered and used for our patients. They are required to adequately clean the teeth, the gums, the tongue, and the dentures. This allows us to target the removal of plaque and tartar buildup. For our patients who are medically fragile, we can introduce a suction to use in conjunction with a standard toothbrush. Or at some of your facilities, you may have a suction toothbrush that allows both tasks to be completed at the same time. These tools should be used for patients who might be NPO or nothing by mouth, have an increased risk for aspiration, or have a reduced level of alertness, or are unable to expectorate their own secretions. Following completion of oral care, it is important to ensure we leave the tissue hydrated and in great condition. This means the application of lip balm, as well as an artificial saliva if the patient suffers from dry mouth. So let's recap these steps. Whether we are seeing a patient for the first time or during the day to complete the prescribed oral care, here's a summary of the steps that should be taken to ensure those 600 species of bacteria have been reduced. First off, you want to put on appropriate PPE, especially now with everything that's going on. Cleaning a mouth can certainly get some debris and some of the patient's saliva on us, so we want to make sure that we are also protected. Place the patient in an elevated position, the same as we would do with any other task where they are going to be having something and the risk for aspiration may be increased. Use a suction or toothette to clear any visible secretions of debris and be gentle on the patient's tissue. Use a soft toothbrush with a small amount of toothpaste to brush all surfaces, including the gums and tongue. Rinse the mouth with water with a sponge and use a suction if needed, depending on the patient's status. Use alcohol-free mouth rinse or swab. Use the toothette to swab it along the surfaces and use a suction to clear of any excess if needed. Apply a water-based moisturizer to the lips and use artificial saliva if the patient has concerns with dry mouth. I encourage you to print off this slide and keep it with you. Although oral care is a pretty routine task for all of us, we get going, we get quick, and this is a quick snapshot of the things you want to do when you're seeing your patients. So how does this look for patients who have dentures? We are going to essentially do the same thing. except we'll be removing the dentures and we're going to rinse in cold water to remove that debris. Thoroughly brush all the surfaces with a soft toothbrush, including the gums and the tongue. Soak the dentures overnight in a denture cleaner to remove the bacteria. It still adheres to dentures. And using a soft bristle brush, like I said, making sure that you're cleaning the gums, the cheeks, and the tongue. And just to reiterate use of the section, for our medically fragile patients who are NPO, if our patient can't swallow and they have a high risk for aspiration or they can't expectorate, make sure that you're using the suction toothbrush, and also make sure that you're placing that patient in a 90-degree angle so that they are safe for anything that may be entering their mouth and unexpectedly going down and could potentially be aspirated. The procedure of oral care may seem time-consuming, and I appreciate how busy our days can be. So like I said before, get your patients and families involved in their own oral care. This may also be beneficial for a client, since dependency for oral care, as we talked about, is one of those predictors for aspiration pneumonia. Are they dependent for oral care? Let's try and give that back to them. Requesting the patient's family to bring in their own cleaning supplies may be helpful. They may have a preference for toothbrush or toothpaste, and this may further promote completing these small but critical acts of oral care. How often a patient requires oral care may be dependent on their severity of dysphagia or the patient's current swallowing status. On their oral health status. You may have SLPs increase or request an increase in the frequency of oral care. You might even hear some of us say, make sure you're doing oral care before and after meals. The reason we want oral care before a meal is to rid of that bacterium, those 10 billion microorganisms, as best we can before the patient with dysphagia is about to complete a task that is going to increase their risk and frequency of aspiration. And as we reviewed earlier, good oral care can move a patient from that high risk zone to low risk in developing aspiration pneumonia, even when the other factors of dysphagia and reduced immune system are present. When oral care is completed at the frequency it is prescribed, this may allow the patient to consume a more liberal diet or advance to thin fluids sooner if they aren't if they aren't being provided that same level of oral care. By overlooking the need for oral care, we may be hindering the patient's progress and progression towards a less restricted and modified diet. So how can your facility support the need for oral care? It is important that we have a protocol in place, and we should have a protocol in place as per our stroke best practice guidelines to help you make these decisions of when to complete oral care and what tools to use. I have an example here for you from the Alberta Health Network, and it's an amazing algorithm, and I'm keen to adopt this at our own facility. Based on a series of questions, this algorithm allows you to easily determine what products to use and how often. So I encourage you to look at this algorithm and take it back to your facilities. Make sure that you have a protocol in place to support oral care following a stroke. Talk to your speech pathologists and get education on the floors. Have them demonstrate oral care to you. It's something that we all do on a regular basis, but when you have to do it on someone else, can be a very different story. Present research on the importance of oral care to your facilities. You have this information. So what are the next steps? Go back to your facilities and be the advocate of oral care, because you know the integral role it has in a patient's well-being and in reducing their risk for developing aspiration pneumonia following a stroke. Encourage your colleagues to practice oral care and educate them on its importance. Speak to your SLPs and your stroke unit managers and your clinical nurse educators, and make sure you are equipped to provide your patient with the best possible care. Know where your oral care tools are and advocate for the appropriate equipment if it is not readily available at your facility. I encourage you to review your facility's protocols for oral care and ask the questions to ensure this basic need is being fulfilled. Download an oral assessment tool. The OHAT and the throat that we talked about earlier are all available online and through your nursing assessment and intervention best practice guidelines. Build a routine for your own care and assessment. And get your hands on a copy of the nursing practice guidelines for oral health. It is a 100-page document. You don't have to read everything, but I promise you it is worth the read and it will give you so much information. I don't know if you can see this, but it is downloadable. I do encourage you to read through it. I have learned a lot just reading through your standards and your guidelines. So when you see your next patient admitted with a stroke, know that you can make a difference from the time of admission. Complete your oral care activity, provide thorough oral care, and then complete that dysphagia screen so you can determine if nutrition and oral medication can be administered. Oral care is a small component of your patient's treatment plan, but it can have such a big impact on their quality of life. The prevention of aspiration pneumonia does begin with oral care. Thank you.
Thanks, Carrie. Great talk. I really appreciate you talking about oral care today. I know when someone comes in and has had a stroke, there's lots of things that need to happen, and maybe oral care doesn't happen right away. So we really appreciate you bringing it back to the forefront today. We're going to take a few questions now. So if you have a question, please type it into the Ask a Question box, and I will read it out for Carrie. I just want to remind you as well to click on the evaluation link for this session. You can find it on the right side of your screen. So for our first question, Carrie, how long should oral care itself take?
Can definitely vary. That's a very hard question to answer because every person that comes into the hospital is obviously going to come in with a different situation orally. We don't know what their status was prior to coming in. So certainly my message, I guess, would be it could very much take a lot longer the first time. So maintenance is key when someone gets into the hospital. Dedicating, even 15 minutes the very first cleaning and ensuring it's done will allow you to do, your standard 2-minute clean thereafter. So very hard to put a timeline on it. But a thorough cleaning when they're in, based on, the status of their oral care coming into the hospital, can certainly alleviate that time for every clean thereafter. So take your time that first instance, and then maintenance will allow you to just, 2 minutes here and there throughout your day, depending on your protocols at your site. You'll find a lot of benefit just from that.
Mm-hmm. Okay, great. Thank you.
Hard to answer, but everyone's going to be completely different.
Yeah, but it's good thought to put the time in the first time around, and then you kind of know what you're dealing with every time you go back to do more oral care. Yeah. Okay, next question is around toothpaste. What do they recommend in terms of toothpaste for oral care?
So in our best practice guidelines, you'll see discussion about chlorhexidine, rinse, or gels, which are, can have some benefit to kill off. There's some really nice studies that show that it can kill off those opportunistic bacteria that are kind of in our mouth. So candida, something like that. Unfortunately, we don't use this at facilities kind of universally. So take a look at your protocols on site, but, a toothpaste that we use at home will be just as good. I know most hospitals will provide a toothpaste to each patient, but toothpaste is toothpaste. It's the thorough cleaning and getting rid of the bacteria. And we already know there's so much research about the toothpaste that are on the shelves at our drug stores. So using those are going to be the most beneficial thing to get rid of any bacteria that we want to in fighting against that aspiration pneumonia that could happen for those vulnerable stroke patients.
Right, right. And speaking of aspiration pneumonia, how does oral care help patients get back to thin liquids?
So I know one of the biggest questions I get on the units, and I know my colleagues as speech paths, is that big question, this person's on thickened liquids, how come? Why can't we get them on that thin fluid? So a really important and beneficial thing about oral care is that we could still see patients on, thickened liquids for meals, but with really great oral care, even that population that's going to aspirate, like we looked at with those pillars, right? Is that it's not just one or the other, it's them happening together, right? Those issues together, not just one at a time. So we can still see those patients on thickened fluids, but if they have really great oral care, we're going to be allowing possible water. So like a free water protocol, if you've heard of that term at your site, to allow water between meals. So when there's no food present, when there's no other type of liquid present, but just water on its own, because we know water is not going to cause a pneumonia, Mm-hmm. It's the bacteria that's rinsed with that. Our body will absorb water. So if you can keep your patients' mouths very clean, that could allow us as a speech path who, has already put a person on a thickened fluid to consider water only between meals, which can actually really help with hydration, help with healing. It's one of the biggest things we fight with patients coming into the hospital is dehydration. So we have access to still allow these patients to have water. It's not an all or none thing. There's other considerations to take in, and oral care is one of them.
Mm-hmm. So when you say between meals, does that include having oral care just before they have this thin water?
Absolutely. Yeah. You want to make sure, before they're having that thin fluid or whatever's going to put them at most risk, is that they're going into that event with as clean a mouth as possible to reduce any risk of that bacteria going into their lungs.
Right. Great. Okay, so I think that's all the questions we have for now. So again, Carrie, thank you so much for taking the time to share your knowledge with us today.